What do Andre the Giant, Maurice Tillet, Richard Keel, Tony Robbins, Sultan Kosan, Zhang Zhengkai, and Erwin Keyes and King Sennacht, who was the Egyptian ruler of the Third Dynasty, have in common? Besides being public figures, they have also suffered from gigantism as children and adolescents, and later on from acromegaly as adults. Gigantism, which occurs during childhood and adolescence, makes people extremely tall, some even reaching the height of 8'11", such as Robert Wadlow. Height is not the only thing in common with people with this condition, but they also have distinct features and health risks that they have to struggle with on a daily basis, which will be discussed further. Acromegaly could be the continuation of untreated gigantism into adulthood or a new onset pituitary tumor in adults. In new onset acromegaly, many are first diagnosed between the age of 30 to 50. At this point, the excess growth hormone affects multiple organs and causes changes in features throughout the body.
In this presentation, we will discuss the cause of this condition, the outcome of having this disorder and distinguishing features, the treatment, and the effect on fertility and overall health. Gigantism and later acromegaly are extremely rare, and endocrinologists may encounter a person with acromegaly once or twice in their careers. The main cause is a pituitary adenoma, a benign yet invasive tumor of the pituitary which secretes excess growth hormone. As we learned in class in the readings, the pituitary is the master gland. It is controlled by the hypothalamus and it affects growth and function of other target organs throughout the body, depending on the hormones that are secreted. The pituitary has an anterior and posterior compartment. The anterior compartment secretes the trophic hormones such as ACTH, target adrenal cortex cortisol known as the HPA axis, TSH, which targets the thyroid to secrete thyroid hormone, FSH and LH, which affect the gonads through the mechanism of the HPG axis, prolactin for lactation, and growth hormone, which targets bones, muscles, and organs. It affects body shape and reduces fat, but it is the main hormone responsible for the pathology in gigantism and acromegaly.
Growth hormone is also secreted by organs that are not the pituitary, like the breast and colon, which help with cell growth. The hypothalamus secretes GHRF, growth hormone releasing factor, which stimulates the pituitary growth hormone in a pulsatile manner, which can cause up to 10 pulses of secretion of GH a day. Growth hormone is also called somatotrophin, which is secreted in specialized somatotrophic cells. The hypothalamic somatostatin affects the anterior pituitary and suppresses the secretion of growth hormone from the pituitary, which can cause a negative feedback loop. Other regulators are insulin, like growth factor, which also inhibits growth hormone. That's why fasting and protein diets increase growth hormone secretion, while high sugar inhibits its secretion. Growth hormone secreted from a pituitary adenoma tumor can become unregulated and in excess will affect growth in these target organs. Growth hormone in a healthy growing person will have a circadian rhythm highest right before waking up and lower before sleep. However, with a pituitary adenoma, growth hormone is secreted out of proportion to the other hormones. Gigantism can occur due to the formation of a sporadic tumor, but in early childhood, it may be due to genetic abnormalities, with some genes being identified called MEN1, or multiple endocrine neoplasia type 1, or even a familial dominant gene that can cause pituitary adenomas in family members. This genetic abnormality is found in Northern Ireland, and hence many stories of Irish giants or the giants of Causeway according to local folklore. There are 5 genes that are responsible for growth hormone that are located in chromosome 17q22.
In healthy people, the pituitary secretes 150 micrograms per kilogram of GH during growth spurts, and after adolescence, it is secreted only in small amounts throughout our lives, remaining at 25 micrograms per kilogram. One can check the concentration of growth hormone in the blood by measuring serum insulin-like growth factor 1, because GH is a precursor to IGF-1. Another test to make a diagnosis is the GH suppression test. As we saw, glucose suppresses growth hormones, so clinicians will give a patient an oral glucose load to check if growth hormone is suppressed. If it is not, then they know that there isn't a normal negative feedback mechanism and there is not normal suppression due to probably a tumor that secretes growth hormone.
Another way to check for gigantism and acromegaly is an MRI with contrast to look at the pituitary gland. Many have pituitary macro or microadenomas and pituitary abnormalities. In children, fast growth is very noticeable. The children are usually abnormally large. They are relatively thin compared to their height. The start of gigantism is usually at age 13 and even sooner in girls. Their heads are also bigger than the average population for their age, and they are diagnosed with macrocephaly. Their extremities, hands and feet, are extremely large, and they sweat a lot. They also have protruding foreheads, a condition called frontal bossing, and they have a protruding jaw, a condition called prognathism. The girls usually do not get their periods, a condition called amenorrhea, and the cause is that the growth hormone and the tumor causes a dysfunction in LH and FSH, which we learned affects the ovaries and uterus. Women with acromegaly can have irregular menstrual cycles. People with acromegaly may notice that their facial features and appearance change. Their shoe size can increase as an adult in only a few years. If the tumor is big enough, it can affect the optic nerve and cause blindness. Adults with acromegaly can continue to have their jaw grow, their tongue grow, and their airway can be restricted, and hence get obstruction and sleep apnea.
The treatment for the pituitary tumor causing gigantism or acromegaly is a surgery called transpedal transphenoidal pituitary surgery, and it is conducted through the nose to reach the pituitary. In 17% of the patients, there is still some tumor remaining, and unfortunately, reoccurrence was found in those less than 20 years old, in 40% of children, and in 5% of adults. Also, the surgery can cause anterior pituitary hormone deficiency in up to 50% of the children, which is very serious since they rely on these hormones for multiple other functions, such as sex hormone stimulation. Gigantism itself can cause multiple endocrine problems, and the surgical complications can cause similar, such as adrenal insufficiency where the adrenal cortex does not produce enough cortisol, excessive need for water and urination due to deficiency in vasopressin, and low thyroid levels to hypogonadism due to low to no sex hormones which are regulated by the pituitary. However, this is still the treatment of choice.
Another treatment is radiation to the area. However, this should be reserved only as a last resort. Radiation can cause many complications, as well as a deficiency in other pituitary hormones, which can lead to many fertility, cognitive, and physical disabilities, especially in children. In this case, the treatment can be worse than the disease. Another treatment that is very effective is octreotide injection, which is a somatostatin analog. As we saw, somatostatin inhibits GH secretion. There are medications like lanreotide and pasireotide, which are sustained-release somatostatin-like medication. Another medication called pegvisomant, which is a competitive GH receptor antagonist. It competes with the GH for the receptor and has shown to help children with gigantism. Gigantism and acromegaly might give impressive stature, but it comes with lifelong hardship from difficulty in mobility and muscle weakness. They suffer from enlarged hearts, a condition called cardiomegaly, over time that failed them. Double vision, since the pituitary tumor can press on the optic nerve, and other symptoms previously discussed. Some scholars, such as Malcolm Gladwell, have hypothesized about the real reason that David was able to beat Goliath. Goliath, according to the Bible, was 6 cubits in a span. Some say 6'9" and some say 9'9". Gladwell hypothesizes that Goliath was actually the underdog, and with an untreated pituitary tumor having gigantism and acromegaly, his eyesight was weak due to the pituitary tumor pressing on his optic chiasm. Therefore, he couldn't see the stone coming towards him. That could explain the shield bearer walking in front of him as his guide. Donnelly et al. Said that his movement was sluggish and his muscles were weak due to myopathy, muscle weakness, which gave David, an agile kid with a slingshot, an advantage of winning because he was healthy. Researchers mentioned that he had sons who were also giants, which may give some clues as to him having the autosomal dominant genetic variation of gigantism. This may only be a hypothesis, but it is an interesting exercise which can teach us about gigantism and acromegaly.